Good evening, everyone. As always, I'm just going to give a minute or so. Still lots of people joining. Okay, right. Good evening, everyone. Before I introduce our speaker for tonight, I would just like to ask of you to be perhaps a little bit more participative in our meetings. We really want this to be not just to be a presentation, but also a discussion. So if you're in the audience and we're struggling with some of the questions and you know the answer, or you just want to join the conversation, then please just raise your hand and we will unmute you. You will then automatically become a panelist member and you will be able to join the discussion. Now, to get things going, I asked Dr. Tim de Meyer to be on the panelist this evening. Tim is a very well-known pediatric gastroenterologist in South Africa, and he is affiliated with Raima Musa and also Wits University. So Tim, thank you for joining us, and I look forward to interesting discussions that will follow the presentation. I'm then going to go on and introduce Chris Hendriksz. So Chris Hendriksz qualified as a medical doctor in South Africa in 1985 from the University of Pretoria. He completed his master's degree in sports medicine at the same university. Due to his own child's rare disease diagnosis, he moved to the United Kingdom and specialized in inborn errors of metabolism across all ages, obtaining his MRCP and FRCP-CH with subspecialty registration. He is an extraordinary professor of human metabolomics at Northwest University Potchefstroom, South Africa, and an extraordinary professor of pediatrics and child health at the Steve Biko Academic Unit, University of Pretoria. He was employed by Nestlé Health Science as the Global Clinical Development Lead for Rare Diseases, Inborn Errors of Metabolism, and Innovative Pharmaceuticals. Currently, he serves as a medical and strategic advisor for a Rare Cause, a non-profit organization based in England that educates clinicians on rare disease management in over 50 countries, with the list growing yearly. This, in his own words, creates hope for those with the least chance of being recognized. He provides expert knowledge to patients, organizations, foundations, regulators, and payers in his field of expertise. Chris has published over 250 papers, with the majority focusing on lysosomal storage disorders, clinical trials, quality of life, clinical guidelines, review papers, and several book chapters in the field of inborn errors of metabolism. And I maybe perhaps also just mention that, if you're joining us from Africa and you don't know Chris Hendriksz, then and you would like some support in rare diseases and inborn errors of metabolism, then you should really reach out to him. So Chris, thank you very much for presenting this evening, and I look forward to your presentation.
Thank you. Let's see if we can get the technology to work, which is the usual challenge. There we go. Everybody sees. And can you see my screen?
Yes, you're good to go.
Okay, good. So today's talk is neonatal cholestasis, but I think important up front is to say all the disclosures. So I will be receiving a honorarium, I'm told, for this lecture, but I can reassure you that Pfizer had no input into the content, and all of the funds will go to our foundation, A Rare Cause. I'm also a consultant for FMCA and already said for A Rare Cause, and I'm a non-prescribing physician, which kind of means I've retired in the UK. So next. First important point to remember is that cholestatic jaundice is never normal. So don't ever come to me and say, I've seen a normal cholestatic jaundice child and I haven't investigated that, because that is completely unacceptable. and that is irrespective of the age. So there is a reason, but maybe important, let's see, can we get a definition? Now, different people use different units, so I've used both for you. But in general, conjugated hyperbilirubinemia is generally defined as a conjugated or a direct bilirubin level greater than 1 milligram per deciliter. It's about 17 millimoles per liter. And you will see I've kind of rounded the numbers. I'm not going to give you the exact numbers. And when total bilirubin is less than 5 milligrams per deciliter, about 85. Or more than 20% of the total bilirubin if the total bilirubin is greater than 85. So that's the definition, but there's a few important clinical things just to remember when you think about this. And this is firstly, when we talk about neonatal cholestatic jaundice, you see a lot of jaundice in the first 2 weeks of life. So some of this is immaturity. So what we tend to do in our practice in the UK is we start investigating children with conjugated jaundice as soon as we detect it, but all children who's gone beyond 2 weeks with jaundice is further investigated. And of course, the most important thing is that especially conjugated jaundice is usually not that easily visible to the naked eye. Just for a little bit of reference, we could usually see the jaundice in the sclera of the eyes around 2 to 3 milligrams per deciliter, about 35 to 50 millimoles per liter. But I can tell you that having seen many jaundice children, and I've seen many, I struggle to spot them below about 80. So you will already see that we will, by eye, miss quite of them. And then, of course, all the textbooks would tell you it's visible between 4 to 5 milligrams per deciliter or 65 to 85 millimoles on the skin. But of course, that's only if you're Caucasian. And I'm really struggling to spot jaundice, especially in our non-Caucasian patients. So it becomes very hard. So why not use something which is easier? And one of the lessons I've learned is that it's much easier to look at stools and talk about stools. Now, naturally, people don't like talking about stools and poop, but it's an incredible source of information for medical people, and we mustn't forget that. So it was interesting to know, and there's many countries in the world that actually use stool screening to pick out their patients with cholestatic jaundice. And I will show you next. And this is the system which is basically used in Switzerland. And basically what patients get is that a family gets sent home with a stool color card. And what they do is when they come for their first visit, they're seen about between 2 and 3 weeks of age. They actually have to record what is the stool color. And according to this, it actually puts them, and you'll see it's nicely marked here, the green, which is normal, and then the red block. Anybody of the parents who responds and says, we've seen some stools in this red block, would be treated as potentially conjugated hyperbilirubinemia. And this is the pale stools which people talk about. So this is a really nice way. So from a practical point of view is, you may not have done it, but when you want to talk to a family, when you see them, ask them about stool and stool color. And of course, and if you're one of these people who's a techie, there are some wonderful new apps available. You can even take pictures of the poop and it'll tell you exactly what it's like. So if that's your thing, go into that. Next thing is, we keep our investigations incredibly simple in the first line. So basically, when we suspect there's conjugated hyperbilirubinemia, we do a liver function and we request for direct or conjugated and indirect or unconjugated bilirubin. Now, our laboratories usually only report the total. So you have to specifically ask, and that's one other thing where people just miss this simple thing. Then we always do a coagulation profile and we do a full blood count. And that's as simple as what we do up front, because we need to establish firstly, does the patient actually have conjugated hyperbilirubinemia before we go any further, and then take it from there. So there's no point doing anything more than that at this stage. What we do next is, I'm sorry, this looks very confusing, but those of you who have listened to my talks before, this is what I call vindicate yourself. Now, we work in a healthcare system where you need to make sure you're not going to be litigated. So this is vindicate is an anagram of the different causes for your differential diagnosis. So I use this frequently. And when I've got a patient and I don't know what the diagnosis is, it keeps my head screwed on to think about all the causes and I don't miss something. And in Africa, most people get stuck here. They look at the infectious causes and they don't go any other way. Or they end up here. And I'm going to push you to the other side now, and you would expect me to do that because a lot of cholestatic jaundice is just called idiopathic neonatal hepatitis, INH. And actually, that is not true because the diagnostic has improved significantly. We now know that actually a lot of the INH, or idiopathic neonatal hepatitis, can be diagnosed. And of course, I've put it in green for you. This is my playing field. So that's why I'm so passionate about this, because about 20% comes from metabolic causes or inborn errors of metabolism, and about 35% is genetic in origin. So more than half of these cases is in my playing field, which is why I think it's really important that people know. Do not put everything in this dustbin of INH and start looking, because there are some really treatable causes, and it's really important that we try and find these. And of course, don't forget that commonly structural causes is there as well, and that's biliary atresia is the commonest cause, or some of these cysts or abnormalities of the bile system. And these are easily fixable and treatable. So it's really important that people don't go to the INH box and we don't do anything more, and rather go to the box and say, cholestatic jaundice absolutely always needs to be investigated and look for common, and you don't need complex investigations. You just need quite a bit of common sense, and I'll tell you how to get there. So what we do next is we always look at the coagulation profile. If that's abnormal, we always give some vitamin K. And if there's no response, we know we're dealing with liver failure, and we run our patients into our liver failure protocol rather than cholestatic jaundice protocol. Simple thing to do, quick and an easy response. We always measure our fat-soluble vitamins and we replace them. And if you can't remember which they are ADEK, A-D-E-K. So Vitadec, if you want to remember the acronym, and that's the way you remember them. And then, of course, we do some imaging, and it doesn't need to be specialized imaging. Ultrasound has become so good and so precise that most of the imaging we now do is just an ultrasound and to see. And then, of course, if you suspect there is biliary atresia, you will do specialist imaging, but that's not what I want the audience to know about. I'm much more wanting to get to some of the basics to think. We tend to consider MCT-based feeding relatively early on, and we do use some bile salt binders with our indicator, and there are different ones. We call them this ursos, ursodeoxycholic acid, and some of the other things depending on itching and things. But really, I don't want to focus too much on that, because I really want to get you to say, do the basics, do them well, and then phone a friend or discuss it with somebody. Because cholestatic jaundice, you can spend a lot of money and do a lot of unnecessary investigations when you just go at it and you don't know the field well. So that's why I say, please go to discuss it with somebody, make your decision on your vindicate and think, do you think it's endocrine, is it gastro, or what is it? Speak to somebody in that field before embarking on it, because firstly, they will also know what's most prevalent in the local populations and take it further. Now, if you're too proud or you want to do it on your own, that's okay as well. Just go to the literature. And I'll show you a complicated figure next. But actually, this is from the Egyptian group. And I actually think it's a really valuable flow diagram. Now, I'm definitely not going to talk you through it, but you've got the reference there, and I've got references at the end as well. And I think it's a really neat way to look at it. So you can see this is what they do. They just split jaundice into two groups, and then you run down the different areas, and it covers a lot of the causes if you want to know what it's all about. So use something like this if you don't want to use a friend, and then at least you will make sure some of the diagnosis. But that's not what I primarily want to talk about tonight. Of course, you would expect me not. What I want to talk about is the IEM, inborn errors of metabolism, treatable disorders examples. And I'm really going to talk about 3 conditions tonight. And it's because when I spoke last, we had a long discussion about galactosemia. And I want to clear this up, that we all understand it better and that we clear. But I can never talk about cholestatic jaundice, but not talking about tyrosinemia type 1. So why is it so important to me? And I'll show you why. So firstly, this is the metabolic defect of tyrosinemia. And for those biochemists, lovely pathway and everything else. But basically what I want you to remember is that firstly, although it says the condition's name is tyrosinemia, many of the patients does not have a very high tyrosine. They may have a higher than normal, but they don't have a very high tyrosine. When they've got a very high tyrosine, it's usually secondary cause or tyrosinemia type 2 or 3, which is less of an issue for me. And I'll explain a little bit more, because they've got mostly skin disease, whereas this condition is really important. So don't get fooled by tyrosine levels. The next thing is I'll post the first question and somebody can put it in the Q&A for me for the discussion at the end. I don't know if succinyl acetone is available in South Africa, because that's the test to look for tyrosinemia. But what we've done in the UK is that our government decided, let's see if we can go back, that it's not viable to screen for tyrosinemia type 1 because actually the prevalence incidence is too low. So what we found out is that actually that because of the pathway, that if we do PBG synthase test, we can actually unpick our tyrosinemia type 1 patients as well. So we've used a porphyrin test, which we now use to diagnose our patients, and then we know which ones to do more specialized investigations on. The other thing is I know that porphyria is very common in South Africa. So if succinyl acetone is not available, maybe PBG synthase is easier to get a hold of. And again, that's a question for those for the discussion at the end, maybe from the lab perspective, what's available. So why is this condition really so important to me? Really this. You see, this is tyrosinemia type 1. It causes 75% of the patients gets liver failure, and the majority don't survive. From the survivors, you end that they get chronic liver disease. But the most devastating of all is that about a third of these, not sure why we're running it, a third of these patients will actually develop liver cancer, and that's before the age of 12. So this is devastating, and it's preventable. They've got renal disease, so they get a tubular defect as well. They get neurological crises, they get a cardiomyopathy. And really, as I've already said, we can potentially pick up these children from succinyl acetone or PBG synthase. And I think that actually this is wrong not to screen for this condition, because this is so preventable, and it's got such good outcomes if you manage this really well. So how do we manage that? Of course, always supportive, nutritional, and we follow them up. And if you don't have access to some of the treatments, what we do in some countries, we have a surveillance program where we do alpha-fetoproteins. We keep following it up. And as soon as the alpha-fetoprotein level starts jumping, we actually refer them for transplantation and further imaging. But most of the time, it's already hepatocellular carcinoma. One thing that is important, if available, nitisinone works dramatic on the acute liver failure. I've seen children turn around their liver failure within about 90 minutes. If they've got tyrosinemia and you've got nitisinone, and you can give it to them. Of course, this is a expensive drug, but it's come off patent and there are multiple biosimilars coming out. So hopefully it will become cheaper and more available. But long-term, really, especially in the low and middle income country, these children need a liver transplant. And from my time I spent on the transplantation unit, we in our team did 5 transplants from a single adult liver, which is why we try and transplant the children as young as possible. So that would be my suggestion. I know transplantation is not the easiest thing. It's got lots of other issues, but for these children, it's life-saving. And if you don't do it, you're going to lose them to liver cancer. So that's that. Next, let's go to galactosemia. Galactosemia, in the simplest form, I told you last time, is basically you've got lactose. It needs to be broken down to galactose and glucose, and the GALT enzyme is involved. And if it was that simple, it would be a lot easier. But let's keep it simple for the time being. And we say basically what tends to happen is that lactose is in many products. It's in milk, It's in cheese, it's in many foods, it's in medicines. And basically what you do is you just restrict the lactose and you make the children well. In essence, that is what you do. And I'll talk a little bit later, but you just replace everything with soya products, which is usually the safest and the easiest because they're much more freely available than some of the other things as well. But what I really want to get to you today, and we spoke quite a bit about it the last time, and it is this one, because there's a lot of confusion and we've created it ourselves. So firstly, when we talk about galactosemia, we tend to talk about GALT deficiency. GALT is the gene. The enzyme is galactose 1-phosphatase uridyl transferase, or GAL1P, as we call it. Now, when we talk about galactosemia, we talk about classical galactosemia or European galactosemia. I've got the mutations in there for you. Our Q188R, as we call them, is the commonest. This is a severe enzyme deficiency. There's usually hardly any detectable, either in liver or in the erythrocytes. And you will usually pick them up on newborn screening. These children has got a susceptibility to E. coli infections because it's got a direct effect on the immune system. But the more important thing is that these patients actually need treating, and there's no controversy about it. They absolutely deserve treatment. They need to be on their lactose-restricted diet for life, and they have multiple other complications which needs to be monitored. Next, in the same GALT gene, we've got two different things, and I've tried to make it easier. There is what we call clinical variant galactosemia and biochemical variant galactosemia. Now, clinical variant galactosemia, as the name says, it's a form of galactosemia which is milder, but it has got clinical symptoms. And that is what we talk about generally when we refer to the African mutation. That's the CR135 or 135L, depending how you want to do it. Now, this is a fascinating condition because if you look at the residual GALT enzyme activity, it's between 1 and 10%, but it seems to be able to recover or improve with age, which we're not entirely sure why this is happening, which is why we find that these patients are incredibly ill as neonates, cholestatic jaundice, liver failure, and some of them even die. But if you capture them, you put them on their lactose-free diet, you pull them through to about 4 or 5 years of age, they actually go into the rest of their life with very little of the other features, the neurocognitive abnormalities, the speech and language delay, as well as the ovarian failure and the endocrine problems. They seem to not have it. Now, one of the theories is that basically the enzyme which we have with in the African variant does not trigger one of the other oncogenes, which is triggered by the classical features. So that's one of the theories at the moment to explain the differences. And then there is the next thing that causes confusion, and this is what's called the biochemical variant galactosemia. So here you've got a biochemical abnormality, but actually the patients are usually not sick. Here you will find the enzyme activity is higher, but the other thing that you find here as well is that the mutations are usually in cis. So that means the mutations is on the same allele. And we think that is most probably why this variant does not have significant biochemical clinical problems, although they've got biochemical abnormality. Now, your problem is, and this is where it gets, so your classical galactosemias, you will capture on your newborn screening. Your Duarte's, you will capture on your newborn screening. But your African variant is frequently not captured on your newborn screening because the levels which they influence in neonate does not breach most of the cutoff levels in the laboratories. So they are the ones which clinically present with galactosemia-like features, but they don't jump out at you at the newborn screening. And the other thing that's important to them, they seem to not have this really E. coli susceptibility. So when you see these kind of patients, they are more likely to be different. Now, we do call it the African variant, but it is being reported in more and more other populations as well. So I'm hoping that clears it a little bit for people who asked previously. So when we look at GALT, There are 3 different variants. Classical, everybody knows. That's the one people tend to know about. Then the non-classical or milder ones, 2 categories. Clinical variant, African mutation, not picked up generally on newborn screening. Clinical symptoms, no E. coli, but gets better with age. And then the Duarte, the variant picked up on newborn screening, but actually clinically normal in general. And then, of course, with all of these, you have to always consider if you have a mutation which becomes a compound mutation, it may change your phenotype. So actually doing genetics is particularly important in these patients to try and solve it. And it also helps you to give some kind of indication. We know our Q188R is the most severe mutation. It's got the poorest outcome, but even in the classical galactosemic group, anything different to that or a Q188R and another mutation tend to have a milder phenotype and a better outcome. Next. Let's see. Next one is galactokinase deficiency. This, as you will see, is very rare, about 1 in 50,000 to 1 in 100,000. What happens with them is they only get cataracts, clinically only cataracts. So once you've got the cataracts, you can't reverse them. You do surgery, you remove them, and it's the end of their disease. But ideally, you don't want them to develop cataracts, so you put them on a restricted lactose diet. What you tend to find is basically an increased plasma galactose, and you also find urinary excretion of galactitol. So that's what you find. So that's galactokinase, or GALK is the gene. The next gene is called GALE, G-A-L-E, or epimerase deficiency. Now here we've got about 1 in 60,000. So again, another rare disease. And maybe I forgot to mention to you, maybe important, let me just quickly, I know I don't like jumping back, but I want to do it. Just classical galactosemia for the numbers is 1 in 45,000. The African variant is about 1 in 20,000, and Duarte is about 1 in 4,000. So that's much more common. Jumping back there. So epimerase, one of the rarer ones. It presents with liver disease, failure to thrive. You've got erythrocyte galactosose, 1 phosphatase concentration elevated, but normal erythrocyte GALT. So they would be healthy newborns, another group with a positive newborn screen. So that's the epimerase deficiency patients. Now, I've had the fortunate privilege of seeing a family with 4 children with epimerase deficiency, but I must say it was fascinating to see how different these children were. The one had quite significant liver disease and hang on to it. The others recovered, and the ones which recovered from their liver disease developed neurological disease later on, which is not frequently reported in the literature. So again, because of the family being highly consanguineous, there may be other confounder genes which describes this, but it is one of the ones to do. And then here for you is the new kid on the block, GALAM, galactose mutaroatase deficiency galactosemia, also called galactosemia type 4. Now, this was discovered as part of the screening program in the US because they found a lot of patients which had positive newborn screens, did not turn out to be GALE, did not turn out to be the Duarte variant as well. So they started looking and they found it, and this is very rare. So it's about 1 in 250,000. But then they found most of the positive cases were African origin, and there the predicted incidence is actually 1 in 10,000. So there may be significantly more of these in Africa. I've put the mutations in there for you, and they are going to come with a different clinical picture. So they basically come with cataracts and transient liver dysfunction and a positive newborn screen. And do you put them on a restricted diet? Of course, it's incredibly controversial because nobody's seen enough of these patients to actually know what makes a difference. But in general, we know that cataracts is driven by galactose. So we always say, put them on a low galactose diet, especially when they're younger, support them, and then at a later stage, have a look if we can discontinue that. So that's the variants. And hopefully now you've seen all 6 variants of galactosemia. Hopefully it makes a little bit more sense. So how do we follow them up? We follow them up by a multidisciplinary team. And of course, as I said, the outcomes depends basically on how quickly or how early you start treating them, and also on the mutation, as I already touched on. Lactose-restricted diet, in most of the LMICs that I work with, just use soya products. There is a huge controversy about soya products and potential effect on estrogen and females. I've had a pragmatic view on this in simple terms. If I don't put them on a soya product, these children are all dead. So I'm not that concerned about the long-term effects of soya products. Time will tell us, and we've looked at our patients, the galactosemic patients who's been on soya products for many, many years, and we've not seen all of the problems which people are assigning to soya, or maybe they are uniquely protected from these side effects. So for me, that's not an issue. Always look at calcium and vitamin D supplementation, because when you're on a lactose-restricted diet, your intakes are poor of these. And if you can't measure them, just give them. These patients need speech and language support, especially those with the classical galactosemia. We do supportive schooling. And of course, we survey. We do a lot of surveying in many of our rare diseases to look for complications. So I need to touch on something else which I can't not mention. And that is something called galactosuria. This is where actually people send a urine sample away to try and look for galactose. And another, it was a screening test people use, they may still do it. And usually it's been said that transient galactosuria is benign, but actually there is a condition which is called citrin deficiency. And it was traditionally thought it only occurs in the Japanese population. We find significant numbers of these children in our cholestatic jaundice patients, which we started reporting, and then other people started reporting, and it's now been reported in all populations of the world. It's no longer an exclusive Japanese or Asian disease, and it's got 3 different variants as well. One of the things you can do, and which I would suggest, is that when you've got transient galactosuria, where you pick up the galactosuria, is to measure serum amino acids. We found in our cohort at least that they all had an elevated citrulline early on. It all comes back to normal. But while they've got their elevated cholestatic jaundice, you will find the galactosuria together with the elevated citrulline. And those are the ones that we actually followed up and the genetic screening on. The 3 variants that you find is the neonatal intrahepatic cholestasis caused by citrin. People call them the NICCDs. There's failure to thrive and dyslipidemia due to citrin deficiency, or FTT-DCD, and then citrullinemia type 2. And citrullinemia type 2 is the most dangerous of these conditions, but they all need relatively the same management. And what is classical of these patients, and they've got an aversion to sugar and sweet food, and that's a poor prognostic sign. And can somebody else put that into the question tab for me as well? I need to know what other condition causes aversion to sugar and sweet food. And you must know that one as well, but this is one of them that causes that. So, and as we go to the next one, how do we manage them? We manage them with a carbohydrate restricted diet. Carbohydrates in this condition actually feeds the disease. So they also get episodes of severe hypoglycemia, which of course is quite challenging to manage when you're trying to restrict carbohydrates. So we've devised some emergency regimes where we use them with very limited carbohydrates, which we use. We survey them as well because we're quite concerned about their liver cancer and their acute decompensations. And really, once we see that these patients are heading to, especially the ones which doesn't tolerate carbohydrate, we consider liver transplantation, or we follow their glutamines and glutamate. We always count them together. We add them up, and if they're more than 1,000, we start getting worrying, and we frequently test their ammonias. The reason for this is these patients are normal. They tend to have, the normal picture is they start with cholestatic jaundice, which they clear. Then they get better. They get a little bit of failure to thrive. Then they get better. They get some dyslipidemia. We're not sure if they go from one stage to the other, or they're different entities yet. And then what tends to happen is they get better through teenage year. And then suddenly they come in with an acute episode of hyperammonemia. And most of the time, they don't survive this episode. So this is really a really challenging disease, and which we keep an eye on, and we kind of move towards transplantation relatively early once we confirm the diagnosis and we know this is where they're heading to. And I just thought this would be really important to put it out there. So I have intentionally left quite a bit of time today for discussions and things, and I hope that's what people want. I've not spoken about all the other courses, and I'm very happy to talk, and people want to talk about PFIC and all these other things. That's absolutely fine. But I thought, keep it simple. Let's look at the management and let's clear galactosemia up for once and for all for everybody. And then we can rather have much more discussion around these, and we can go to those questions that I've put out in the chat already, and the Yes, You're Reading list. So I'm going to stop sharing the screen and hand it back to the moderators.